Hi, welcome to my channel. Today, we are going to see about esophageal varices. Esophageal varices is dilated, tortuous veins in submucosa of esophagus caused by portal hypertension. Risk factors are portal hypertension, which is elevated blood pressure in veins that carry blood from the intestines to the liver, is caused by impaired circulation of blood through the liver. Collateral circulation subsequently develops, creating varices in the upper stomach and esophagus. Varices are fragile and can bleed easily. Portal hypertension is the primary risk factor for the development of esophageal varices. Second risk factor is alcoholic cirrhosis and viral hepatitis. Older adult clients frequently have depressed immune function, decreased liver function, and cardiac disorders that make them especially vulnerable to bleeding. On assessment, we can identify hematemesis, melena, tarry stools, ascites, jaundice, hepatosplenomegaly, dilated abdominal veins. Physical assessment findings are bleeding, esophageal varices, hypotension, and tachycardia. The client may experience no manifestations until the varices begin to bleed. Activities that precipitate bleeding are the Valsalva maneuver, lifting heavy objects, coughing, sneezing, and alcohol consumption. If bleeding is suspected, 1. Establish for access with a large bore needle. 2. Monitor vital signs and hematocrit. Type and crossmatch for possible blood transfusions. 3. Monitor for overt and occult bleeding. Medications. Non-selective beta blockers, propranolol, Inderal, are prescribed to decrease heart rate and consequently reduce hepatic venous pressure. Used prophylactically but not used in emergency hemorrhage. Vasoconstrictors, forced synthetic vasopressin and natural somatostatin have been proven most effective to increase portal inflow. Vasopressin, desmopressin, and octreotide, sandostatin, are avoided due to multiple adverse effects. Nursing considerations: vasopressin cannot be given to clients who have coronary artery disease due to resultant coronary constriction. Potent vasoconstriction may also cause problems. Procedures: endoscopic injection, sclerotherapy or variceal band ligation. Ligating bands can be placed and/or injection. Sclerotherapy can be performed during an endoscopic procedure. Used only for active bleeding and not prophylactically. Nursing actions: administer pre-procedure sedation. After the procedure, monitor vital signs and take measures to prevent aspiration. Sclerotherapy carries a greater risk of postoperative hemorrhage. Antacids and/or H2 receptor blockers are administered postoperatively. Esophagogastric balloon tamponade. An esophagogastric tube with esophageal and gastric balloons is used to compress blood vessels in the esophagus and stomach. Nursing actions: check balloons for leaks prior to insertion. Monitor placement of the tube and observe for possible obstruction of airway. Monitor for aspiration into the lungs and secretions or blood from the esophagus. Provide oral suction as needed. Maintain balloon pressure at prescribed pressure for prescribed time to decrease risk of esophageal or gastric necrosis from ischemia. Complications: hypovolemic shock due to hemorrhage from varices. Nursing actions: observe for manifestations of hemorrhage and shock, tachycardia, hypotension. Monitor vital signs, hemoglobin, HCT, and coagulation studies. Replace losses and support therapeutic procedures to stop and control bleeding. These are the main points of this subject. Thanks for watching and subscribe the channel for more videos.